For those of you that are online, thanks again for joining us for another Lunch and Learn regarding the release of the new Diabetes Canada Clinical Practice Guidelines. We'll just start off with a reminder for those that are joining today that please do mute your lines. I know we're getting some feedback from a couple areas, so could you please double check that your lines are muted, so you can mute your line with the microphone button or *6 to mute your line. We will open up for questions and discussion as we work through the presentation, and I'll give you information as to how to unmute at that time. But welcome, thank you for joining us today. Today's topic that Dr. Richard Phillips is going to be presenting on is diabetes in pregnancy, and providing some highlight on the updated guidelines on that topic. Dr. Richard Phillips, for those of you that haven't joined us at a previous Lunch and Learn, is an adult endocrinologist that joined us in the Interior Health region just about a year ago, works out of Kelowna, practice out of Kelowna, and also is our regional medical lead for diabetes. So very happy to have him giving of his lunch hours over these upcoming weeks and the past few that we've had around sharing information around these clinical practice guidelines. So we'll pass it over to Dr. Phillips to get started with the presentation.
Right. Thanks, Angela. So I've got the bouncing ball here. Welcome, everybody. I hope that everybody has read the Chapter 36 on diabetes in pregnancy. It's actually a monster chapter. It's the biggest one out of the entire guidelines. And it'll take you a couple of days to get through it. In keeping with the length of the chapter, the number of slides that Diabetes Canada has provided for this section is monstrous as well. There were like 93 slides for this particular chapter that they have available online. So I'm not going to go through 93 slides, obviously, but I'll go through each of the recommendations that they have, and we'll spend more time on some than others. And there's a few things that I think are a little bit contentious, and I'll bring those up when they come up. And some things are a bit new. Much of it is not much different from the 2013 guidelines. So without further ado, indeed, longest chapter, I agree. 42 recommendations. So recommendation 1 is stressing the importance of preconception care for women with pre-existing diabetes, both type 1 and type 2. Outcomes are improved when pregnancies are planned and if patients are followed and their health is optimized in an interdisciplinary setting prior to pregnancy. Clearly, it's important for people to be on reliable birth control until they're ready to pursue a pregnancy, and it's important for us to remind them that they'll need to be on prenatal vitamins and folic acid and get off teratogenic drugs prior to pregnancies. So all reproductive age women, we need to discuss this intermittently with them to make sure that they're prepared prior to pregnancy. So this is the first half of the presentation is dealing with women with type 1 and or type 2 diabetes, and then GDM is later on. So recommendation 2, clearly those women with polycystic ovarian syndrome in the setting of type 2 diabetes, if they happen to go on insulin sensitizing drugs such as metformin, that may improve their ovulatory status, and so we need to be reminding these women that they're more likely to get pregnant if they're starting on metformin or if they're on a program of significant weight loss that will improve their fertility. So they need to be prepared about that. So type 1, type 2 preconception counseling, ideally recognizing that in type 1 diabetes, this occurs perhaps 50% of the time in many jurisdictions, and in type 2 diabetes, it's much less than that. So preconception counseling tends not to occur as often in women with type 2 diabetes. So we'll have to try to do a better job with that, seeing as the numbers of reproductive age women with type 2 diabetes is increasing due to increasing weight and people putting off pregnancies to later ages. Okay, so the idea is to reduce complications, including congenital malformations related to hyperglycemia, by getting the A1C down effectively preconception. Although they say ideally preconception A1C less than 7%, if possible, we should be striving for an A1C of less than or equal to 6.5% preconception, if it can be done safely, with the idea that by the third trimester, ideally to reduce macrosomia events, A1C is less than 6.1% or 6% or less by the third trimester. Difficult targets to achieve, but that is currently the goal, to reduce complications, including congenital malformations. This is a change, is my understanding, with regards to the folic acid supplementation. So prenatal vitamins and folic acid for 3 months preconception, and I used to recommend 4 to 5 milligrams of folic acid for women with diabetes. Now they're saying that the evidence is only there for the 1 milligram dose of folic acid as opposed to higher doses, so they've adjusted their recommendation in that regard. And of course, we should be getting rid of teratogenic medications preconception, including statins, ACE inhibitors, and ARBs. The literature on ACE inhibitors and ARBs with regards to pregnancy, a little bit mixed. They're suggesting that certainly by the 2nd and 3rd trimester, that the ACE inhibitors and the ARBs are absolutely contraindicated. If a woman gets pregnant while on an ACE inhibitor or an ARB, that doesn't seem to be a problem, but that it simply means they need to switch to something else in the 1st trimester if they happen to be on an ACE inhibitor or an ARB, specifically labetalol or alpha-methyl-dopa or a calcium channel blocker. Moving right along, I thought this was interesting. I'll just read it word for word. So preconception care, women on metformin and or glyburide may continue on these agents if glycemic control is adequate until pregnancy is achieved. Women on other anti-hyperglycemic agents, DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, need to switch to insulin prior to conception. I guess my only comment there would be that there are many women with type 2 diabetes that are not meeting glycemic targets on metformin and or glyburide, and for those people, they should be switched to insulin preconception if they're not meeting glycemic targets. I used to see, not uncommonly, people on metformin preconception, they'd have good A1Cs, good blood sugars. They would confirm a pregnancy, and then they would get referred to the diabetes clinic, and it may take 2 to 4 weeks to get into the clinic, in which time the physician has asked the patient to stop the metformin. So they have 2 to 4 weeks without any medication, and the blood sugars go up, and that's clearly not the right thing to do. So until they are switched to insulin, then the metformin and glyburide can continue. Ideally, the microvascular complications would be assessed for preconception.
Sorry, we have someone that's got their phone off mute. If you could please all check your lines, ensure you're on mute with *6. Thank you.
Thanks. I'll open it up for questions in a minute. So as far as the microvascular screening, ideally women with type 1 and type 2 diabetes would have an eye exam preconception, and ideally, again, in the 1st trimester, PRN thereafter during pregnancy and within a year of delivery, simply because diabetes may accelerate development and or progression of diabetic retinopathy. So that hasn't changed. It's not easy to accomplish, but that's the recommendation. As far as other microvascular complications, looking for albuminuria, evidence for chronic kidney disease, preconception. Clearly, if patients have albuminuria or reduced GFR, significantly increases the risk for preeclampsia and preterm delivery in that setting. So nothing new there. The interdisciplinary care when pregnant is an ideal situation. Diabetes physician with nurse educator, dietitian, obstetrician, etc. The women with type 2 diabetes, most of them are going to require a switch to insulin. You'll have the rare case of metformin doing the job throughout pregnancy and still meeting glycemic targets. The majority of people will require insulin. Non-insulin anti-hyperglycemic agents are not approved for use in pregnancy. So, of course, both type 1s and type 2s, the ideal regimen is either basal bolus insulin with an MDI regimen or insulin pump therapy. The targets are strict, and they remain unchanged at fasting and preprandial less than 5.3 pre-meal. If you're doing 1 hour postprandial sugars, less than 7.8 1 hour, less than 6.7 2 hour, that's unchanged. A1C less than 6.5% at conception if possible, and less than 6% by the 3rd trimester. If hypoglycemia is limiting, then you'll have to relax those targets. The reason for the strict targets is even if people have A1Cs in the type 1 population, A1Cs between 6.5% and 7% by the 3rd trimester, the rate of macrosomia is still incredibly high, 50% plus. So the only way that we can really make a dent in reducing macrosomia rates and the attendant complications is actually to get the A1C down into the non-diabetic range. Very difficult to do. Some patients are able to do it. These days with CGM potentially and either MDI or pump therapy. So especially if they've only had their diabetes for a few years. So it is theoretically possible. It just takes a lot of work. And certainly for type 1s and most type 2s, we'll be doing the blood sugars pre-meal and bedtime, as well as 1 or 2 hour postprandial. So it's a lot of tests. The weight gain that's recommended by Diabetes Canada is based on the gestational weight gain targets as per the Institute of Medicine, and the Diabetes Canada appendix does have recommendations for weight gain based on preconception BMI, so those can be easily looked up. The insulin to use in pregnancy, generally for type 1 and type 2 patients, we use rapid-acting insulin analogs. Strictly speaking, the data suggesting improved glycemic control with analogs compared to regular or Toronto insulin isn't that great. There is some evidence of better postprandial control with the analogs. So generally speaking, Diabetes Canada is recommending either NovoRapid Humalog or Apidra for type 1 diabetes and type 2. For type 1 diabetes, we're using long-acting insulin analogs preferentially. For type 2 diabetes and for gestational diabetes, I think NPH insulin for a basal insulin is perfectly fine. They're much less likely to develop hypoglycemia, especially in the 2nd and 3rd trimester. Both type 1 and type 2 patients, of course, will be prone to hypoglycemia at the end of the 1st trimester. So that's the danger period to watch. In pregnancy, now this is something that I haven't been doing in the past, but it looks like I'll be doing it now. Women with pre-existing diabetes, type 1, type 2, should start ASA, 81 milligrams daily, at 12 to 16 weeks gestation to reduce the risk of preeclampsia. I think that's a new thing for me anyway. I'd be interested to hear if other people have been doing that routinely as well, or if this is a new thing. Seems new to me. They make some specific recommendations for patients who will be receiving betamethasone for fetal lung maturation in the 3rd trimester as to what to do to increase the basal and bolus insulin to avoid hyperglycemia and potentially to avoid DKA in type 1s. So there's the guidelines do describe recommended increase in dosing on the day of the first dose of betamethasone and lasting for the next 4 to 5 days. So, this is interesting. This is based on a recent study. They're suggesting that women with type 1 diabetes at least consider or be offered real-time CGM to improve glycemic control and reduce complications. This was based on a study called the Concepts study. And in fact, Dr. Denise Feig, who is the lead author of this chapter, was, I believe, the lead author in that particular paper as well. It was in The Lancet within the past year. And they found that in type 1 diabetes patients who were on CGM, that although as compared to capillary blood glucose checks, that the A1C difference was minimal. It was only like 0.2% difference, but there was a reduction in neonatal complications, including neonatal hypoglycememia and duration of stay in the NICU and the frequency of hyperbilirubinemia. So it does seem to have an effect on outcomes in type 1 diabetes. I'm not an obstetrician, so I'm not making decisions with regards to fetal surveillance and timing of delivery, so that's generally made by the maternity folks. So here are the recommendations with regards to non-stress tests and induction of labor. That's really not changed at all. And this isn't changed either. So during the active stage of labor, both for type 1, type 2, and gestational diabetes for that matter, we're aiming for blood sugars between 4 and 7 millimoles per liter to reduce the risk of neonatal hypoglycemia. And patients who are on insulin pumps during labor, if they feel comfortable continuing the pump, then certainly the evidence suggests that they should be encouraged to do so, as the outcomes seem to be favorable when that's been looked at. So unless there's extenuating circumstances, meaning that they may need to switch to an insulin infusion, but generally patients may remain on pumps. And postpartum, of course, we have to recognize that insulin requirements are reduced immediately as soon as the placenta is delivered. And the reduction in doses can be as much as 30 to 50% less than the total daily dose that was given preconception, at least for a few days to a week or so. You know, greatly reducing the insulin doses postpartum is necessary, even less than the preconception dose, at least temporarily. Therefore, they need to check their blood sugars frequently. And then they make some recommendations about recommending breastfeeding, of course, recognizing that the frequency of women continuing on with breastfeeding is less in type 2 diabetes than it is in the general population for a number of reasons, but that there are benefits to mom and baby with the usual recommendations of breastfeeding for 4 months and continuing, if possible, to some degree for upwards of 2 years postpartum. The one thing that's unique about type 1 diabetes is a high rate of autoimmune thyroid disease in these women, and thus we should be, if women have positive TPO antibodies identified either preconception or in the first trimester, that we should be looking for development of postpartum thyroiditis with TSH testing 6 to 12 weeks postpartum. So before we go on to the gestational diabetes section, why don't we open it up a little bit now and if anybody has any questions.
Great, thank you. Just a reminder for folks to come off mute, just #6 to open your line, and we'll take questions or comments at this time.
Dr. Phillips, I have a question for you. With the use of NPH in pregnancy, because that's what we've always been using. If you have someone who's quite non-compliant to taking the second dose of NPH, so she's good in the morning, but she's not good at supper time, would you consider putting a person like that on Levemir or Lantus and hopefully get the once-a-day coverage?
Now, is this for GDMs or for type 2s, right? Yeah, I think that would be a reasonable thing. I mean, I guess the problem is, I mean, these people are quite insulin resistant, obviously, and an NPH has certain advantages over the long-acting analogs due to the fact that they do have that kick to them, you know, that sort of that peak effect that is often required in order to you know, to deal with the insulin resistance. When you have insulins with flatter profiles, you don't get that kick. In some cases, it doesn't work as well. But I think that would be a reasonable idea. But you know, generally speaking, for GDMs and type 2s, you know, I think NPH is the drug of choice otherwise. But in that special circumstances, that sounds reasonable.
Okay, and if you were to do that, would you have a preference over Levemir versus Lantus?
Well, if we're sticking to the once-a-day thing, it would probably be Lantus, because I mean, certainly there's a large proportion of patients that do require Levemir twice a day, whereas once a day would be fine for a Lantus situation. So I guess it would be Lantus.
Okay, thank you.
You're welcome. Any comments on the change in the folic acid and the aspirin recommendation?
With the aspirin, it's only grade D evidence, so would you still be recommending it?
I think a lot of the recommendations end up being grade D, don't they? It's, I think the idea behind it is to reduce the preeclampsia. So I guess if it may not be a blanket statement. If you have a woman who's got no microvascular complications and an excellent blood pressure and has only had type 1 diabetes for a relatively short period of time and is relatively young, I think that would be perhaps a case you wouldn't do it. But for other cases, you know, I guess, you know, I think I'd be interested to hear what the maternity docs would have to say about that recommendation. Maybe we should bring that to their attention, saying that this is in the guidelines, it's grade D. What do they think about that? Because they're generally the ones that are making that recommendation with regards to preeclampsia risk and so on. I'd be interested to hear what they have to say.
I've got a question here, Kamala.
It's Barbara in Canada. I actually have two questions. The first one is monitoring kidney function in pregnancy. I'm just wondering if you can speak to that, how often, what parameters. And the second one was ketone monitoring with women with type 1 diabetes.
Yeah. Sure. I knew the ketone thing was going to come up. So as far as the kidney function is concerned, if the albumin and the GFR is normal preconception, I'm not in the habit of monitoring that throughout pregnancy. It's only if the GFR is abnormal or if there is evidence for micro or macroalbuminuria that I would be doing it at the same frequency as the A1Cs. So the A1Cs would be done at least every 3 months, potentially every 2 months. So that's been my approach to it. It's not specifically mentioned in the guidelines. As far as the ketone thing, it's remarkable that there's very little mention of the role of ketone testing in the guideline. I'm just going through the various pages here, and it's so lengthy I can't seem to find it. But there. I want to actually. Here we go. If you're looking at the guidelines, it's on supplement page 269 under monitoring, and I'll quote, and this is under the GDM section. In an effort to control their blood glucose by diet, women with GDM may develop starvation ketosis. Older studies raise the possibility that elevated keto acids may be detrimental to the fetus. While the clinical significance of these findings are questionable, it appears prudent to avoid ketosis. So for the GDM crowd, you know, there's no recommendations specifically for monitoring ketones. I think what my practice has been is if there's a concern that a woman is you know, not gaining weight appropriately, or if there's a fear that they're restricting their carbohydrates excessively, that we would be checking ketones, looking for evidence of starvation ketosis to reintroduce carbohydrates in that setting. In type 1 diabetes, I think all patients with type 1 diabetes in pregnancy should be able to test either urine ketones or capillary ketones as part of sick day management or for unexplained high blood sugars, and especially for those who are on insulin pumps. So every patient who's on an insulin pump, I've been recommending that they have a meter that allows them to do capillary ketone testing under those circumstances, because, of course, the pump patients, if they have a lack of insulin delivery due to a kinked catheter or an infusion set that's plugged for whatever reason, they only need to go 3 or 4 hours without insulin delivery before they'll start developing ketones. And in that situation, we know that, you know, ketoacidosis in type 1 diabetes in pregnancy has a very poor prognosis as far as the baby's health is concerned if it's allowed to continue. So I'm a bit paranoid about ketones in type 1 diabetes, especially in pump patients. But it's remarkable, the guidelines don't, they're a bit silent on the ketone question, and that's a bit surprising, I must admit. Shall we carry on? Shall we blast through the GDM section? Okay, so they talk about trying to prevent GDM in the first place, and the importance of healthy diet and weight loss, which can be helpful in reducing GDM. And if one develops GDM in the first pregnancy, if one is able to reduce one's body weight through healthy diet prior to the next pregnancy, you can actually reduce the risk of GDM in subsequent pregnancies. They're continuing to recommend universal screening for GDM in all women, not doing selective screening, screening at 24 to 28 weeks. Again, much like the last guidelines, they have a preferred approach for screening versus an alternate approach. Their preferred approach is the 2-step with a 50-gram challenge, followed by a 75-gram glucose tolerance test thereafter if they fail the 50-gram. And the alternate test is the standalone 75-gram OGTT. Where it gets difficult, of course, is that both the preferred approach and the alternate approach do have a 75-gram OGTT component to them, but there are different glucose criteria for what is abnormal for both those circumstances. So it makes things very confusing for physician and even for the lab to be able to keep these things straight. And of course, the 75-gram glucose tolerance test results are clearly different from the non-pregnant state. So it's just a bit confusing. I know in Victoria we use the 1-step model just to try to avoid confusion, recognizing that the 2-step approach has much more data and outcome data associated with it. Diagnosis. Now this was interesting, and I'd be interested to hear what people have to say about this, and I'm not entirely sure I know what to do with this. Let's just read this particular recommendation. So women identified as being at high risk for type 2 diabetes should be offered earlier screening than 24 to 28 weeks with an A1C test at the first antenatal visit to identify diabetes. If there was any thought that they might have a spuriously high or low A1C due to a hemoglobinopathy or some other thing, then a fasting blood sugar should be done. And so in in the first trimester, they say that you should follow non-pregnant criteria for diagnosing diabetes. So A1C over 6.5%, fasting blood sugar over 7. If they meet that criteria, you should be considered diabetes in pregnancy and treat as such. If you're lower than those, they say, you know, then do your screening as per usual at 24 weeks. Now, what I would do, of course, I'm sure many people in the audience would do this as well, if I saw an A1C that was between 6 and 6.5%, if I saw a fasting plasma glucose that, quite frankly, was between 5.3 and 6.9, I would say, well, that's clearly abnormal. And at the very least, I would be offering these women, you know, follow-up through the GDM clinic with home glucose testing to see if they're meeting their targets, with dietary therapy to see whether they actually need to be on insulin. So they don't specify that, but there's a huge gap between, you know, having, you know, high risk for diabetes, first trimester, you know, do you have diabetes or not, versus, you know, well, you may not have type 2 diabetes first diagnosed in pregnancy, but you may have sufficiently high blood sugars to justify treatment. Now, because there's no data to suggest that treatment of that latter group is beneficial, they kept it out of the guidelines. But I must admit that I'd still be treating those people, or at least following them closely. I'd like to open it up for on that point as well, Angela, if you don't mind.
Yes, of course. Again, pound 6 if anyone would like to comment on that point raised.
Well, maybe everybody's in agreement with me that they would do the same thing. So clearly some people need to be screened before the usual time, and if the sugars are higher than the glycemic targets that we're looking for, you know, in the third trimester, I'm still, you know, following these folks closely. Okay, well, let's move along. So weight gain, again, per Institute of Medicine guidelines, nutritional counseling. I'll leave this to the experts who are the dietitians, but specifically they're suggesting a low glycemic index diet to replace high glycemic index foods, and spreading the carbohydrates throughout the day with snacks, including bedtime snack, as per usual. Nothing new there. And if the dietary management is unsuccessful at getting down to targets within 2 weeks, then we're generally looking at basal bolus insulin therapy, targeting the insulin to where the sugars are high. If, for whatever reason, patients decline insulin, the drug of second choice in GDM is metformin. And if, for whatever reason, they don't tolerate metformin, drug of third choice would be glyburide. Fetal surveillance is generally up to the maternity people and or the midwives with non-stress tests and ultrasounds and induction of labor. Those decisions aren't made by me, but if I have any concerns, I certainly contact other team members to let everybody know what's going on. Glucose management in labor the same as type 1s and type 2s. Breastfeeding recommendations, no different. One thing that is often not accomplished by our patients is for them doing a redo 75-gram glucose tolerance test within 6 weeks to 6 months of delivery to see whether their diabetes has resolved, whether they have impaired glucose tolerance, to help predict their risk of diabetes in the future. Of course, the importance of maintaining a healthy body weight prior to the next pregnancy to avoid GDM the next time. And I think we can probably leave it at that. I think that's it. Recommendation 42, yeah, we got through it on time. So let's open it up again.
Great, yeah. Star or pound 6 to unmute your lines if you have any additional questions around the gestational diabetes management or earlier type 1, type 2 management questions.
Dr. Phillips, I do have a question in regards to the 1 hour versus 2 hour post-testing. Seems like there's different opinions out there as to which one to use, and recently I came across a discussion where they said that there was stronger evidence for the 2 hour post rather than the 1 hour post. I've always done whichever one's higher. I typically have women check one day 1 hour and the next day 2, and then we pick the one that's higher, which to me makes more sense than just relying on 2 hours, because I think we could miss a number of people that way. What is your opinion?
Yeah, it's not written in stone for sure. So women with type 1 especially, I guess it could be GDMs as well. Are you talking about GDMs, type 1s, type 2s, or?
Mostly the GDMs, because that's the bulk of who we see.
Right. So in GDMs, I've generally been recommending 1 hour, and if that is not possible for whatever reason, you know, I'm happy to fall back on the 2 hour thing. I haven't been specifically looking at 1 versus 2 and picking the higher one. I mean, that makes sense. I mean, generally speaking, under normal circumstances, the blood sugar is at its highest. So in between them, so just a little bit beyond the 1 hour mark is sort of a postprandial peak. My practice has been 1 hour. I've been settling with 2 hours if it's necessary. I think your plan sounds like a good one. Yeah, I mean, if there's a problem with one or the other, then focus on that.
Okay, thank you.
Other questions from those on the line? Again, #6 to come off mute if you'd like.
Just a comment that we had from a patient that was kind of told by, I guess, a healthcare professional that in GDM, starting insulin would, I think her words were, age the placenta more rapidly, and that was one of her concerns about starting insulin, because that's what she had heard. Mm-hmm. Is that something you've heard, or? No. No, okay.
Afraid not. Yeah, the issue of placental insufficiency is interesting. The guidelines do talk about the commonly seen reduction in insulin requirements in the 3rd trimester in GDMs, type 2s, and type 1s, and they say that the evidence that reducing insulin requirements is truly associated with placental insufficiency is a bit weak, and they downplay it a little bit, although I must confess that I don't downplay it. And I think they may have, there was an article that came out, I think it must have been within a year, within a year from now, that may not have been included in the guidelines. But this particular study showed that there indeed was an association between a 20% drop in insulin requirements in diabetes of all types and evidence for placental insufficiency. Now, placental insufficiency clinically is associated with reduced fetal growth, and oligohydramnios, and potentially on ultrasound abnormal Doppler flow in the umbilical cord, and potentially even a ragged-looking placenta on ultrasound. So, placental insufficiency, the baby doesn't look as if it's getting full nutrition, so it's affecting its growth, and this can be anticipated by a drop in insulin requirements. So my sort of practice has been, and this more recent study has sort of strengthened that practice, that if we see a drop in total daily dose insulin requirements of more than 20%, that I'm letting somebody know, the maternity doctor, to ensure that there's at least once, if not twice a week, non-stress tests being done and ultrasounds being done, looking specifically at the health of the placenta under those circumstances. So, most of the time it's going to be a false alarm, but sometimes it's not going to be a false alarm, and I just don't want to be in that situation where you miss something important.
Thanks.
I have a question. In the postpartum screen to test for prediabetes or diabetes, do you think, I would think it would be, could they do like the fasting blood glucose or an A1C rather than have to do the sugar test? Because I wonder how many women aren't going to do that or don't end up doing that. And couldn't they just monitor those parameters?
Yeah, I mean, you'd think the uptake of that would be a lot better. And certainly, you know, if they've had gestational diabetes, doing either a fasting glucose or an A1C once a year thereafter, I think is justified. I think that what they talk about in the body of the guidelines is that the sensitivity of the 75-gram test is better than the fasting or the A1C, and that's why they're sticking to that particular thing. Of course, it's interesting to note that if you take 100 women and you do all 3 tests on them, 75-gram glucose challenge versus A1C versus fasting glucose, they're not going to be perfectly overlapping results for each person. So it's going to be like a Venn diagram. So each test will pick up a certain segment of women, whereas other ones won't. So as far as sensitivity is concerned, they're still recommending the glucose test, but you know, the uptake's not that great. But that's the reason.
Thank you.
Okay. Well, if there's no other questions or comments from the line, I'd just like to thank you all again for taking your lunch hour, and especially Dr. Phillips again for presenting. Just to mention again, if you're looking for the guidelines, you can find them online at guidelines.diabetes.ca. As well, we are recording these sessions, and upon completion of all the lunch and learns, we'll be posting them, and an email notification will come out to you as attendees, so you can re-listen or share with colleagues if they weren't able to join us today. And we do have another Lunch and Learn coming up next week with Dr. Phillips on special considerations for acute coronary syndrome, heart failure, and renal patients in diabetes management. So join us for that if you haven't already signed up. And thanks again for attending. Thank you, Dr. Phillips.
Thank you.